Welcome to my favorite topic, heart failure. In this presentation, you will learn how to diagnose, treat your patients with guideline-directed medical therapy, and document accurately so that you can take the best care of your patients. I'm Kate Morgan, an acute care nurse practitioner at WakeMed Heart and Vascular at the Cary location. I'll tell you a little bit about me. I've been at WakeMed Heart and Vascular since 2012, and before that I was a hospitalist, a nurse practitioner. I have a passion for teaching and mentoring, and I do this across several social media platforms, including a cardiology blog at thecardsnp.com. I'm also involved with the American Association of Heart Failure Nurses, where I serve as chair of the social media committee. I also precept nurse practitioner students, and I'm an ambassador and mentor for POCN, which is Point of Care Network for nurse practitioners and physician assistants. I do have an associate status with the American College of Cardiology and certification in heart failure nursing. And lastly, I am in a doctoral program at UNCW for DNP. My goal for this presentation is to define heart failure and its classifications and to discuss heart failure guideline-directed medical therapy for heart failure with reduced ejection fraction and walk you through a case study. So first, let's define heart failure. And my definition comes from the Universal Definition and Classification of Heart Failure that was published in 2021. So this document was a writing committee that came up with a universal contemporary definition of heart failure that's comprehensive and practical. So their definition is that heart failure is a clinical syndrome with current or prior symptoms and or signs of heart failure, and that is caused by functional or structural abnormalities. Now on the slide, I point out on the echo findings what you would see that would determine functional or structural abnormalities. In addition to that, you also have to have either elevated natriuretic peptides or evidence, objective evidence of cardiopulmonary or systemic congestion. So we know that as, looking objectively at a chest x-ray. Do they have pulmonary vascular congestion? Do they have exam findings of crackles, elevated jugular venous pressure? Do they have an S3 heart sound? And symptoms such as orthopnea, paroxysmal nocturnal dyspnea, dyspnea on exertion, etc. Now let's discuss the difference between heart failure and cardiomyopathy. Heart failure, as we previously discussed, is a clinical syndrome where there are signs and symptoms, objective data, and elevated natriuretic peptides. Cardiomyopathy is more of a general term that refers to structural and functional heart muscle dysfunction. When seeing a patient for heart failure, first decide if they are in clinical heart failure, and then decide, is this acute new onset heart failure? Is it acute on chronic? Is it chronic and compensated? Once you have the echocardiogram results, you can further classify the diagnosis. ICD-10 diagnoses codes are looking for the word systolic and diastolic, but it's preferable to use the nomenclature that are used in the guidelines. And the subclassification based on ejection fraction is HFrEF, which is an EF of 40% or less, HFpEF, which is 50% or more, HF mid-range EF, 41 to 49%, and another category that is improved, and that's either written as HFpEF improved or HFIMEF. And here's a documentation example, acute on chronic heart failure with reduced EF. In your documentation on admission and at discharge, document the New York Heart Association functional class and the ACC-AHA stage. The patients with NYHA functional class may improve with treatment. So class 1 refers to no physical limitations. Class 2, slight limitation with physical activity in the form of moderate exertion. Stage 3, marked limitation of physical activity with minimal exertion. And stage 4 is at rest, they're short of breath. So typically in the hospital, a lot of patients tend to come in as a class 3, and as we diurese them, they improve to a class 2 or hopefully 1. Now, the ACC-AHA stages will progress as the patient's heart failure worsens. We tend to see the patient most in stage C in the hospital, which refers to that they have structural heart disease with past or current symptoms of heart failure. Now we'll focus the discussion on heart failure patients with reduced ejection fraction, which again is EF 40% or less, and with New York Heart Association class 2 through 4 symptoms, since this is the target population for guideline-directed medical therapy. So these classes briefly include the angiotensin receptor neprilysin inhibitor, which is also called ARNI, our ACE inhibitors, and our ARBs, evidence-based beta blockers, aldosterone antagonist, and also hydralazine and a nitrate. And I want to mention that our organization is awarded by the American Heart Association following the Get With the Guidelines heart failure program. Throughout the rest of this presentation, I'm going to focus and highlight these guidelines. So the first class of drugs I want to talk to you about for guideline-directed medical therapy are the ARNIs, ACE inhibitors, and ARBs. I'm sure you've heard of the Paradigm-HF trial, which was a landmark trial that compared sacubitril/valsartan against enalapril with patients with an ejection fraction of 40% or less and New York Heart Association class 2 through 4. They met their endpoints, primary and secondary endpoints, and revealed a significant reduction in all-cause mortality, cardiovascular mortality, or heart failure hospitalizations. Now, the Paragon-HF trial looked at patients with an ejection fraction of 45% or greater, and that was a comparison between sacubitril/valsartan and valsartan. They did not meet their primary or secondary endpoints, but in a post hoc analysis, the FDA has recently declared that sacubitril/valsartan is indicated for patients with heart failure and low normal ejection fraction. So also in trials, they found that ARNIs can be started as first-line therapy in the hospital. Now, of course, there are some contraindications and things we have to watch out for. First of all, if they've been on an ACE inhibitor, we have to stop that ACE inhibitor for 36 hours before starting sacubitril/valsartan. And we need to really closely monitor creatinine, potassium, and blood pressure. Blood pressure tends to really be a problem. It lowers blood pressure significantly. It's a good medicine if the patient has high blood pressure. And also, it can tend to elevate potassium and elevate creatinine. Now, if you cannot go with sacubitril/valsartan, alternative is an ACE inhibitor if cost is an issue. So you could use lisinopril or enalapril, for instance, but again, the same side effects as sacubitril/valsartan. You have to watch out for creatinine, potassium, and of course, blood pressure. Now, an ARB comes to play if the patient develops a chronic dry cough on an ACE inhibitor. You can then switch them to valsartan and candesartan. But now with the new guidelines, it's really recommended as first-line treatment to try to start an ARNI first over an ACE inhibitor or an ARB. Now let's talk about the evidence-based beta blockers. So as you know, the beta blockers block the adrenergic receptors alpha-1, beta-1, and beta-2 to reduce the sustained activation of the sympathetic nervous system. 3 beta blockers are used in chronic heart failure with ejection fraction of 40% or less and have been shown to reduce cardiovascular mortality or heart failure hospitalizations. Coreg blocks alpha-1, beta-1, and beta-2 and best used in patients with high blood pressure. Bisoprolol and Toprol XL block the beta-1 receptors in the heart. It is recommended to start with an ARNI, ACE inhibitor, or ARB, first in new onset heart failure with reduced ejection fraction, and add in a beta blocker when euvolemic. However, if the patient is already on a beta blocker, it's okay to continue it during the heart failure admission, but you may need to reduce the dose. The slide shows the 3 different evidence-based beta blockers and the dosages and the trials that were associated with each. Aldosterone antagonists are potassium-sparing medications that block the effects of aldosterone. It was the RAILS trial that first recognized the mortality benefits of spironolactone. These patients had an ejection fraction of less than 35% and were already on an ACE inhibitor, loop diuretic, and in some cases also digoxin. Now, the EMPhASIS trial established the significant benefits of adding a eplerenone to an ACE inhibitor or ARB and beta blocker. The EPHESIS trial found mortality benefit post-acute MI complicated by left ventricular dysfunction and heart failure. So on the slides, I gave you the dosages of each of these medications and what the target dose you want to achieve. Now, let me note that with spironolactone, this could cause painful gynecomastia, and in that case, you could then switch it to a eplerenone. Both you have to watch out for with hyperkalemia, and these medications are contraindicated if potassium is greater than 5.5 or creatinine greater than 2.5 or creatinine clearance below 30. Hydralazine and nitrate. So the AHEF trial was the African American heart failure trial, which established a significant reduction in death from any cause and rate of the first hospitalization for heart failure with patients with heart failure and reduced ejection fraction and New York Heart Association class 3 to 4, already on standard therapy, which included an ACE inhibitor, beta blocker, and diuretics, with the addition of hydralazine and isosorbide dinitrate. Retrospective analysis for the SOLVED and VHEF trials suggested that African American patients derive less benefit from an ACE inhibitor than other ethnicities. So on the slide, I gave you the dosages for hydralazine and isordil, and note that these medications are TID dosing. So now let me present to you a simple case of heart failure. This is a 65-year-old white male with a history of hypertension and dyslipidemia. He's a former smoker, and he presented to the emergency department with dyspnea on mild exertion, productive cough, and bilateral lower extremity edema. And his vital signs are as listed. Notably, he has a low-grade temperature and very high blood pressure and only an 88% oxygen saturation on room air. Your objective data shows chest x-ray that has pulmonary vascular congestion, an EKG that's normal sinus rhythm, and no ischemic abnormalities. Lab work is significant for a BNP of 600, normal basic metabolic panel, mildly elevated white blood cell count, and troponin that's normal. His home medication include losartan 50 milligram daily and Crestor 10 milligrams nightly. I've compiled a list of important questions to ask your patient during your history and physical. Number one, what's the most activity you can do without feeling short of breath? Do you have to sleep propped up? How many pillows? Are you sleeping in a recliner? And when did that start? Do you wake up grasping for breath at night, which is paroxysmal nocturnal dyspnea? Any recent weight gain, abdominal bloating, or feeling full easily? Does your significant other tell you that you snore or stop breathing? And do you have any chest pain or palpitations? Your physical exam findings are abnormal for moderately elevated jugular venous pressure, and which worsens actually when you press on his right upper quadrant, which is the hepatojugular reflex. Heart rate's regular, no murmurs, rubs, or gallops. He does have 1+ bilateral lower extremity edema by basilar crackles. He is wearing 2 liters nasal cannula, and he's able to speak in full sentences without looking tachypnic. Abdomen is soft, non-tender, and positive vowel sounds. Now, diagnostics and treatment. In the emergency department, they put him on oxygen. They gave him a dose of IV Lasix, 40 milligrams. They gave him aspirin and nitropaste, and they called the hospitalist for admission. The hospitalist, suspecting pneumonia with his elevated white blood cell count and low-grade fever, started him on IV antibiotics, continued the aspirin, continued his home medication of losartan, and continued the nitropaste. Now, our orders consist of cycling the cardiac enzymes, ordering an echocardiogram, and since he's going to be continuing on IV Lasix, 40 milligrams twice a day, we're going to add daily basic metabolic panel and magnesium levels and make sure that they're at a goal. Potassium should be at a goal of 4.0 and magnesium 2.0. Also order input and output and daily weights and a lipid panel for the morning. So now we get the echocardiogram results back, and it reveals no wall motion abnormalities, but the ejection fraction is 35 to 40%, and diastolic dysfunction stage 1 is also noted. He does have left ventricular hypertrophy and mild mitral regurgitation. So here are your diagnoses. Number 1, acute heart failure with reduced ejection fraction. New onset. Echo has been done and revealed an ejection fraction of 35 to 40% with diastolic dysfunction stage 1. ACC AHA stage was completed, and he's a stage C, and NYHA functional class 3. Number 2 is hypertensive heart disease with heart failure and on losartan 50 milligram daily at home. Dyslipidemia on Crestor 10 milligram nightly. Now, deciding on what guideline-directed medications to start will be patient-specific and dependent on renal function, blood pressure, and potassium level. If you have a higher pressure and the renal function is okay, then starting low-dose Entresto would be preferable. Again, if they have been on an ACE inhibitor, then that needs to be stopped for 36 hours before we can start Entresto. And consider the timing of adding an evidence-based beta blocker. If the blood pressure is on the lower side, choose Toprol XL. It has less impact on blood pressure as opposed to Coreg. Consider adding an aldosterone antagonist before discharge if renal function and hyperkalemia has not been a problem. If the patient is African American, then consider adding hydralazine and isosorbide dinitrate. Now, the SGLT2 inhibitors have now been recognized as beneficial for patients with heart failure and reduced ejection fraction. Dapagliflozin, which is also known as Farxiga, has been approved by the FDA to reduce the risk of renal disease cardiovascular death, and hospitalizations for heart failure, but it is not indicated for patients with an eGFR less than 25. So now let's get prepared for discharging the patient. You need to review the current and home medication list, and of the guideline-directed medications that we did start, can any of them be titrated up before discharge? Are they adequately diuresed and ready to go home? For any of the new cardiac medications, make sure you prescribe them and make sure they have refills and coupon cards. Arrange a follow-up in our office for 7 days, and you have to mention that in your note by stating the date, the time, who the provider is that is seeing the patient, and that the follow-up is for heart failure. And that's per the Get With the Guidelines program. And also, have they received heart failure education from the heart failure nurses? If the patient is being started on an aldosterone antagonist, you have to remember to order a basic metabolic panel within 7 days as a clinic collect. Also consider checking a BNP before discharge to establish a baseline if the patient's euvolemic. And referral to cardiac rehab if the patient has an ejection fraction of less than 35%. So this slide is for those of you that see patients in the outpatient clinic. So post-hospitalization, the 7-day heart failure follow-up should include these following points. Assessing the volume status and medication compliance. Consider up-titrating guideline-directed medical therapy, and if not, give a description in the office note as to why you cannot do that. That's really helpful for if they become decompensated again and they come back in the hospital and we're reading those office notes. We really need to see what your thought process was about why they couldn't tolerate the medications. And are they on all of the recommended guideline-directed medical therapy? Do you need to introduce another drug class? So please discuss that in your office note that you've thought about adding the drugs, the new drug therapy, or up-titrating. And if you could not, then please tell us why that is. Also assess for social determinants, risk for decompensation and readmission. Adjustment of therapy should be considered every 2 weeks. So it's not that you're just seeing the patient in the heart failure clinic 7 days post-hospital discharge, but you really need to be seeing them quite frequently, maybe even a video visit, so that you're keeping on top of how they're feeling, if the medications are working, and if they're tolerating the medications. You can repeat the echocardiogram in 3 to 6 months after achieving target guideline-directed medical therapy to consider a device such as an ICD or a CRT. And consider referral to an advanced heart failure specialist when you think that is indicated. So let's also talk about the 2020 ACC/AHA Heart Failure Performance Measures. From this document, I included a few important points, and one is to make sure that in the outpatient setting, you're documenting clinical symptoms of current activity level for all the heart failure patients. This can include the New York Heart Association functional class or a disease-specific validated questionnaire like the Kansas City Cardiomyopathy Questionnaire, a 6-minute walk test, or peak oxygen consumption. So in the clinic setting, make sure you're documenting one of these. And also, as previously mentioned, when starting an aldosterone antagonist, order a basic metabolic panel to evaluate potassium and renal function within 7 days. One other point is consideration for ICD and cardiac resynchronization therapy. Key points for taking care of heart failure patients. Number 1, get a good clinical assessment of volume status. with your physical exam, including jugular venous pressure, and using measures such as the New York Heart Association functional class. Number 2, evaluate the echocardiogram, the basic metabolic panel, your natriuretic peptides, and blood pressure to determine appropriate heart failure treatment. And number 3, keep a close eye on these patients to be sure they're tolerating the heart failure medications and to continue heart failure education and hopefully up titration of good guideline-directed medical therapy.